Usually, when we think about a medical diagnosis, there's this underlying expectation of precision. It feels almost like engineering, right?
Oh, totally. Like it's just black and white.
Exactly. You break your arm, the x-ray shows that stark, jagged white line against the black background, and the doctor just points at it, says, there it is. That's the problem. It's incredibly binary.
Right. It's either broken or it's not.
Yeah, but then you step into the world of hands-on, daily patient care, and suddenly that x-ray machine is completely useless. We're no longer looking at binary problems. We're trying to navigate this incredibly nuanced, constantly shifting landscape of human needs.
Which is honestly, that's the absolute definition of complex person-centered care. There is no one-size-fits-all formula when you are dealing with someone's dignity, their comfort, and frankly, their physical safety on a day-to-day, hour-to-hour basis.
Right. And that gray area, that immense responsibility, is exactly why we are here today. Before we dive in, I want to take a second to give a huge, warm welcome to you, the listener.
Yes, welcome.
If you are tuning in with us right now, it means you've made the decision to pursue your CNA certification. You are stepping into a role that is, without a doubt, the absolute backbone of healthcare. So truly, congratulations on making this choice. We're thrilled to be on this journey with you on the Cert Prep Academy CNA Exam Prep podcast.
It's an incredibly challenging path, but I can tell you from experience, it is one of the most rewarding things you will ever do. I mean, you are going to be the person who makes the biggest difference in your residents' daily lives.
But let's just be totally real for a second here. Studying for the NNAAP written exam can feel paralyzing.
Oh, absolutely paralyzing.
You look at the sheer volume of skills, all the specific protocols, the tiny details that seem, completely contradictory, and it's just a lot. It feels like you're trying to drink from a fire hose while someone is shouting instructions at you.
It really does.
But I want to assure you right now, you are not alone. You just sat down with two friends who are going to be your study partners, and, well, we're going to get you through this.
We're going to break these concepts down so they actually make sense in the real world. We aren't just going to give you a list of random rules to force into your short-term memory.
Right, because rote memorization only gets you so far.
Exactly. Because once you understand the why behind a clinical procedure, the actual human physiology involved, you don't even have to memorize it. The right answer just becomes, the only logical choice.
So let me lay out how the series works. This is an 11-part series that covers absolutely everything you need to know for all 6 of the NNAAP written exam topic areas.
Every single one.
Yep, and every single deep dive stands completely on its own. So if you're taking practice tests and you realize, oh man, my infection control knowledge is terrible, you can just jump straight to that specific deep dive.
Which is so helpful for targeted studying.
Right. But if you want to cover everything from scratch, starting right here at episode 1 and working your way straight through to episode 11, we'll cover the entire exam. And all the questions, the clinical scenarios, and the concepts we're unpacking today are pulled straight from the Cert Prep Academy question bank.
Which is crucial because understanding the material is only half the battle, really. The other half is understanding how the exam writers formulate their questions and spotting the very specific traps they set.
Exactly. So today is episode 1, which focuses on physical care part 1, personal hygiene and grooming. When I look at the scope of practice for a CNA, hygiene seems like the most fundamental task, but it also seems like the area with the highest potential for hidden dangers. So where do we actually start unpacking this?
We have to start with the water, specifically bathing and skincare. And I'll tell you right off the bat, prioritizing resident safety over everything else is like the biggest hurdle on the exam for this topic.
Let's dig into that, because when we talk about bathing safety, water temperature is the first thing that comes up. The rule is that the water should be lukewarm to warm, so around 105 to 110 degrees Fahrenheit, or 40 to 43 degrees Celsius.
Yeah.
And the CNA must be the one to check it.
Always.
But I play devil's advocate here. If I'm drawing a bath for a resident, why is the burden entirely on me to test it? I mean, if I run the water, why can't I just ask the resident, hey, put your hand in, does this feel too hot to you?
It's a completely logical question, but it gets to the very core of understanding the geriatric population. You cannot rely on the resident to tell you if the water is scalding them because, well, so many of the people you care for have severely reduced tactile sensation.
Wait, really? You mean their skin literally can't feel the heat?
Precisely. Think about the physiological changes of aging. As we age, the epidermal layer of our skin thins out dramatically, but beyond that, you're dealing with systemic conditions.
Like what kind of conditions?
Yeah, things like peripheral neuropathy from diabetes or just generalized poor circulation. The nerve endings in their extremities are damaged. They aren't sending the appropriate danger signals up the spinal cord to the brain.
Oh, wow. So you could have a situation where a resident is sitting in like 130-degree water, which is actively destroying their skin tissue, causing second or third degree burns, and their brain just isn't registering it as pain.
Exactly. Or consider a resident with advanced Alzheimer's disease. Their skin might feel the burn, the nerves might send the signal, but their brain lacks the cognitive ability to process that signal as a threat.
So they wouldn't know to tell you it hurts.
Right, or they lack the verbal skills to tell you to stop. By the time you notice their skin turning bright red, profound tissue damage has already occurred. That's why the exam writers are so strict about this. You test the water first, always.
Okay, so the temperature is 105 to 110 degrees Fahrenheit. But practically speaking, I'm not carrying a digital thermometer around in my scrubs. How do I, as the CNA, accurately test it?
You test it on your own body first, but specifically on your inner wrist or the inside of your elbow.
Let me guess the physiology there. The skin on the inner wrist is much thinner than the skin on the palm of the hand, right? So it's a closer proxy for the fragile skin of an elderly resident.
You hit the nail on the head. The calluses on your hands can withstand much higher temperatures without feeling discomfort. The inner wrist gives you a highly sensitive, accurate read on whether that water is going to cause a thermal injury.
That makes total sense.
Yeah, so the clinical sequence is you test it on your inner wrist first. Once you confirm it's safe, then you have the resident touch it to verify it's comfortable for them.
Safety first, comfort second. I
Yeah.
like that. And looking at some of the wrong answers that pop up on these exams, they'll throw in options like make the water as hot as the resident can tolerate to kill bacteria.
Which is a terrifying trap. A bathtub is not an autoclave. You're not trying to sterilize a human being. I mean, water hot enough to kill surface bacteria would literally melt their skin. We remove bacteria during a bath through mechanical friction.
Just the rubbing of the washcloth.
Exactly, the physical rubbing of the washcloth with mild soap and water, not through boiling temperatures.
Okay, that leads us perfectly into the actual mechanics of the bed bath. Because you mentioned mechanical friction, but there is a very strict, almost rigid order in which we have to wash the body parts.
The overarching principle here is that you must always wash from the cleanest area of the body to the dirtiest area.
I always try to visualize this like washing a car. If I'm washing my car, I'm never going to take the sponge I just used to scrub the brake dust and mud off the tires and then wipe it directly across the windshield.
No, of course not.
I'd just be grinding abrasive dirt into the glass. It's the same concept for the human body, but instead of dirt, we're talking about microscopic pathogens.
That analogy holds up perfectly. So if we apply that to human anatomy, where's the windshield? We start with the face, and specifically we start with the eyes. You wash the eyes using a clean, wet washcloth. But the critical detail here is absolutely no soap.
Because the mucous membranes of the eye are way too sensitive for alkaline soaps. And the technique is specific too, right? Inner to outer.
Yes, you wipe from the inner aspect of the eye, so the tear duct near the nose outward toward the ear. And you must use a different clean corner of the washcloth for each stroke.
Oh, that's a good point.
Because if you wipe outward and then bring that same piece of cloth back toward the nose, you're just dragging whatever bacteria or crust you just removed right back into the tear duct.
Okay, so we've done the face, then we work our way down. Arms, chest, abdomen, legs, and I'm assuming the tires in my analogy, like the absolute last thing we wash is the perineal area.
Yes, the genitals and the anal region are always last. That area houses the highest concentration of bacteria on the human body.
Right, especially GI bacteria.
Exactly, particularly gastrointestinal bacteria like E. coli. If you washed the perineal area first, and then used that same water or washcloth to wash a skin tear on their arm or their face, you are literally inoculating vulnerable areas with intestinal bacteria.
That sounds like a disaster.
It is. That is how systemic, life-threatening infections begin in nursing facilities.
And what about the water itself? The exam asks about changing the bath water. Are we just using one basin for the whole process?
Not at all. You change the bathwater throughout the process, particularly before you move to the perineal area. The primary reason is to drastically reduce that infection risk we just talked about, but it's also to maintain that warm water temperature so the resident doesn't start shivering.
Speaking of shivering, let's talk about the environment during this or bed bath. The resident is lying in bed being washed. The exam frequently asks why we only expose the specific body part we are currently washing.
You use a bath blanket for that. If you are washing the right arm, only the right arm is exposed. The rest of the body stays covered. Once that arm is washed and dried, you cover it back up before moving to the chest.
I feel like the instinctual answer is just, for privacy and dignity, which is obviously true. Nobody wants to lie entirely naked while someone bathes them.
Yeah.
But I know the test writers, they usually want the physiological reason.
They do. Dignity is paramount, but the clinical danger is massive heat loss. Elderly bodies have lost a lot of their subcutaneous fat.
The insulating layer under the skin, right?
Yep. Their basal metabolic rate is lower, meaning they don't generate heat as efficiently as younger people. If you pull the blankets completely off a wet, elderly resident in a facility that has the air conditioning running, their core body temperature will plummet.
Oh.
They can actually become hypothermic right there in the bed. So keeping them covered is a critical intervention to regulate their core temperature.
That's fascinating. The bath blanket is essentially acting as artificial subcutaneous fat while they're wet. Okay, let's look at an emergency scenario because we are dealing with wet surfaces and medically fragile people. A scenario from the practice material says, a nursing assistant is bathing a resident in a tub, and the resident suddenly reports severe dizziness and feeling faint. What is the immediate action?
This is a classic prioritization question. They want to know what you do first. And the trap answers will always sound somewhat helpful, like tell the resident to put their head between their knees or leave the room immediately to go get the charge nurse.
Leaving a dizzy person alone in a tub full of water? That sounds like a fast track to a drowning incident.
It's the most dangerous thing you could do. If they lose consciousness, they will slip under the water in seconds. The correct immediate action is to stop the bath and pull the plug to drain the tub.
Drain the tub. That's such a specific mechanical action that I feel like someone could easily forget in a panic. But the logic is bulletproof. You eliminate the environmental hazard immediately. If the tub is empty, they can't drown, even if they pass out.
Exactly. You drain the water, you assist them to a safe seated or lying position outside the tub, and then you use the call light or call for the nurse. You never abandon a vulnerable resident to go find help.
So we've washed away the surface bacteria, we've kept them warm, and we've managed the water hazards. But a huge part of hygiene is what happens after the bath, drying them off and managing the integrity of the skin itself. Which brings us to the topic of pressure ulcers and repositioning, which I know is a massive chunk of the NNAAP test.
It has to be. As a CNA, you are the front line of defense against skin breakdown. The nurses administer the meds, the doctors write the orders, but the CNA is the one physically inspecting that resident's skin inch by inch, every single shift.
Let's start with the golden rule of bed rest. If a resident cannot move themselves, how often is the CNA required to reposition them?
Every 2 hours, at a minimum.
Every 2 hours. Yeah, Cert Prep Academy breaks this down really well in their free study guides. They really emphasize that every 2 hours rule because it can be applied to so many different exam scenarios. But I want to really dig into the why here. Why is it 2 hours? What is actually happening inside the body if we just leave someone lying on their back for 4 hours?
To grasp that, you have to visualize what a pressure ulcer, a bed sore actually is. It isn't a surface scrape. It's a localized injury to the skin and underlying tissue.
Right.
When a resident lies perfectly still, gravity is pulling the entire weight of their body down into the mattress. Now think about the human skeleton. There are points where the bones are very close to the surface of the skin. We call these bony prominences.
So we're talking about sacrum at the tailbone, the back of the heels, the shoulder blades, the elbows.
Those bony prominences act like hard points of pressure. They are essentially crushing the skin, the fat, and the muscle against the resistance of the mattress.
That sounds painful just thinking about it.
It is. Now, inside that crushed tissue are microscopic blood vessels called capillaries. They deliver oxygen and nutrients to the skin cells. When the pressure from the bone exceeds the pressure inside the capillaries, those tiny vessels are squeezed completely shut.
So the blood flow just stops.
It completely stops, and tissue cannot survive without oxygen. If that pressure is not relieved within roughly 2 hours, those skin and muscle cells begin to suffocate and die.
Oh, wow.
The tissue becomes necrotic. That dead tissue forms a crater, which is what we call a pressure ulcer. So when we turn a resident every 2 hours, we aren't doing it to, stretch their muscles or keep the sheets clean, we are physically lifting that heavy bone off the capillary bed to let the blood rush back in and feed the tissue.
So on the exam, if they ask for the primary reason for frequent repositioning, the correct answer is always about preventing pressure ulcers by maintaining vital blood circulation. Not muscle exercise, not comfort,
Or
blood flow.
correct. But here's the catch. How we move them to relieve that pressure is just as critical as how often we move them.
Okay, let's explore that. Say I have a resident who has slowly slid down toward the foot of the bed over the last few hours. They are heavy, but I'm strong. Why can't I just reach under their armpits and drag them back up to the head of the bed?
Because if you drag them, you will induce two forces that will literally tear their skin apart: friction and shearing.
Friction, I understand. That's two surfaces rubbing together, like the resident's dry skin dragging against the coarse cotton bed sheets. It's like a rug burn. But what exactly is shearing? The exam brings up shearing constantly.
Shearing is far more insidious than surface friction. Imagine the resident's skin is slightly damp from sweat, so it sticks firmly to the bedsheet.
Okay.
When you grab them under the arms and yank them upward, their skeleton and their deep muscle tissue move toward the head of the bed. But because their skin is stuck to the sheet, the skin stays exactly where it is.
Oh, wow. So the internal structure of the body moves, but the external wrapper stays put.
Exactly. And the tissue connecting the skin to the muscle is violently stretched and torn. Blood vessels are ripped in half deep beneath the surface. You might not even see a mark on the top of their skin immediately, but you've just caused massive deep tissue necrosis. That is a shear injury.
That sounds horrific. So if dragging causes friction and shearing, how on earth do we move a heavy resident safely? What is the procedure the exam wants to see?
You must use an assistive device, specifically a draw sheet or a lift sheet. This is a folded sheet placed laterally under the resident, spanning from their shoulders down to their thighs.
Right, I've seen those.
When it's time to move them, you and another nursing assistant stand on opposite sides of the bed, grasp the rolled edges of the draw sheet, and on the count of 3, you lift the resident entirely off the surface of the mattress, move them up, and gently set them back down.
So the draw sheet acts like a hammock. By lifting them completely, you've removed the mattress from the equation. Zero friction, zero shearing.
Exactly. You are lifting, never pulling or dragging.
Let's talk about what happens if a resident already has a pressure ulcer. Say they have a stage 2 pressure ulcer on their heel. For context, a stage 2 means the top layer of skin has broken open. It might look like a ruptured blister or a shallow pink crater. How does the CNA handle washing that specific area?
Extreme gentleness is the rule. You cleanse the area using warm water and a very mild soap. You never use hot water because that compromised tissue is incredibly vulnerable to thermal damage.
Makes sense.
Once it's clean, you carefully pat the area dry. You never, ever rub it. And then you immediately report your observations to the charge nurse.
And the exam will try to trick you here, right? What are the trap answers for treating a stage 2 ulcer?
The most common trap answer is to massage the reddened area or the ulcer vigorously to stimulate blood flow.
I can see why people fall for that. If the problem is a lack of blood flow, rubbing it seems like it would help bring the blood back to the surface.
It's a logical assumption, but clinically it is disastrous. If the tissue is already dying or inflamed from pressure, applying deep physical massage just crushes those fragile capillaries even further. It accelerates the tissue death. You never massage a pressure ulcer or a reddened bony prominence.
Okay, let's talk about general skin hydration. After the bath, we want to apply lotion to keep the skin from cracking. Is there a specific technique for applying lotion that the exam focuses on?
Yes. The optimal time to apply moisturizing lotion is when the resident's skin is still slightly damp after patting them dry.
Why damp? Why not wait until they are completely air-dried?
Because lotion doesn't just add moisture, it acts as an occlusive barrier. If you apply it to slightly damp skin, the lotion traps that microscopic layer of water against the epidermis, locking the hydration in. If the skin is bone dry, you've missed that window of opportunity.
But there is a massive, incredibly important exception when it comes to applying lotion, particularly regarding the feet.
Yes, this is a non-negotiable rule. You never, under any circumstances, apply lotion between the toes.
Which seems counterintuitive because the skin between the toes gets dry and flaky too. Why is that area off limits?
Think about the anatomical environment between the toes. It's a tight, dark, naturally warm space. If you pump a layer of moisturizing lotion in there, it doesn't evaporate. It just sits there, creating a super hydrated, warm greenhouse.
Oh, yuck.
Right. That is the exact perfect breeding ground for severe fungal infections and bacterial overgrowth.
And I imagine if the resident is diabetic, that fungal infection goes from being an annoyance to a literal life-threatening crisis.
Exactly. Diabetic residents often have compromised immune systems and terrible circulation in their feet. A fungal infection between the toes can quickly cause the skin to crack open, allowing aggressive bacteria like staph to enter.
Because there's no blood flow to fight the infection.
Right, it spreads to the bone, and within weeks you are looking at a toe or foot amputation. So, as a CNA, you apply lotion to the top of the foot, the bottom of the foot, and the heel, but you skip the webbed spaces between the toes entirely.
That cascade from a little bit of lotion to an amputation is terrifying, but it really highlights why these tiny details matter so much. Okay, so their skin is clean, dry, and protected. Now we have to transition to getting them dressed. Let's look at the mechanics of dressing, particularly when a resident has suffered a stroke.
This is one of the most heavily tested scenarios on the exam. They want to see if you understand how to navigate unilateral weakness when one side of the body is paralyzed or profoundly weak.
Here's the classic scenario. A resident has left-sided weakness following a stroke. You are assisting them with putting on a button-down shirt. Which arm goes into the sleeve first?
The ironclad rule is always dress the weaker or affected side first. So if the left side is weak, the left arm goes into the sleeve first.
Let's unpack the biomechanics of that. If I'm dressing myself, my instinct is to use my dominant, strong arm to start the process. Why do we force the weak arm to go first?
It's all about physics and available slack. Think about the motion of putting on a jacket. You slide your first arm in pretty easily. But what happens when you try to get your second arm in?
You have to reach backward, twist your shoulder joint, bend your elbow at an awkward angle, and stretch to find the armhole, right?
Right. It takes a lot of flexibility and range of motion. If you put the resident's strong arm in first, you have now tethered the shirt to that side. Now you have to take their paralyzed, weak, and often painful arm and force it into that awkward backward twisting motion to get it into the second sleeve.
That sounds like it would hurt.
It causes immense pain, and because the muscles are often spastic after a stroke, you could easily dislocate their shoulder joint.
Ah, I see. But if you start with the weak arm,
You start with the weak arm, the shirt is completely loose, there's no tension. You gently slide the sleeve up the limp arm without bending the joints unnaturally.
oh, that makes so much sense.
Once the weak arm is safely in, the resident can use their strong arm, which still has full range of motion and strength, to reach back and easily navigate the second sleeve.
That is brilliant. It's about protecting the compromised joint. And then when it's time to take the shirt off at night, the process is completely reversed.
Right. Undress the strong side first. Taking the sleeve off the strong arm first creates the slack you need to just let the garment slip right off the weak arm without pulling it.
Let's create a memory aid for this. Because when you're sitting in the exam room, stressed out, it's really easy to get weak side, strong side, on, off, totally jumbled up.
My favorite mnemonic for this is DF, dress affected first.
DF, dress affected first. I like that. Or I've heard the phrase, on with the weak, off with the strong.
That's a great one. On with the weak, off with the strong. If you repeat that to yourself, you will effortlessly pass any dressing sequence question they throw at you.
Let's stick with external grooming and talk about nail care. The exam asks how a CNA should cut a resident's fingernails. The options are usually A, cut them into rounded shapes down into the corners, B, cut them as short as humanly possible, C, use bandage scissors, or D, cut them straight across and file the edges smooth.
The correct choice is D. You always use proper nail clippers, you cut straight across the nail, and then you use an emery board to file away any sharp corners.
Why straight across? Why not round them out like a manicure?
Because digging into the corners of the nail bed to create a rounded shape drastically increases the risk of creating an ingrown nail. As the nail grows back, it pierces the surrounding skin, leading to severe pain and infection.
And what about cutting them short?
You never cut them extremely short because you risk clipping the living tissue under the nail, which causes bleeding.
But I know the exam throws a massive curveball here. I was looking at the Cert Prep Practice Bank earlier, and they have a question that specifically changes the scenario. It asks, what if the resident who needs their nails clipped has diabetes?
That is a hard stop for a CNA. If a resident has a diagnosis of diabetes or severe peripheral artery disease, or if they're taking anticoagulant medications, blood thinners nursing assistants are legally and ethically prohibited from cutting their nails.
Why does diabetes change the rules of basic grooming entirely? I mean, they still need their nails crimped.
It goes back to that physiological cascade we discussed with the lotion between the toes. A person with advanced diabetes often has profound peripheral neuropathy.
So they can't feel their extremities.
Right. They cannot feel their toes or fingers well. If you, the CNA, accidentally nick their skin with the clippers, they might not feel it. Because diabetes severely damages the microscopic blood vessels in the extremities, there is hardly any white blood cell response or oxygen reaching that tiny nick.
So it doesn't heal like a normal cut.
It doesn't heal at all. The cut remains open, it ulcerates, bacteria enter, and it progresses to a severe bone infection called osteomyelitis.
Wow.
I cannot stress this enough. A simple slip of the nail clippers by a CNA on a diabetic resident can literally result in the amputation of a limb. That is why diabetic nail care is strictly the domain of a licensed podiatrist or a specialized wound care nurse.
So what can the CNA do for a diabetic resident's nails?
You can soak their hands in warm water, use an orange stick to gently clean dirt from under the nails, and you can use an emery board to gently file down rough edges. But the clippers stay in the drawer.
That really underscores the gravity of the CNA role. You aren't just performing chores, you are actively managing immense medical risks.
Let's touch quickly on hair care before we move on. If a resident has thick, heavily matted hair, what is the protocol? You never, ever take scissors to a resident's hair to cut out a tangle unless you have a specific doctor's order and explicit permission from the family and the resident.
So what do you do?
The protocol for matted hair is patience. You apply a detangling solution or conditioner, take a wide-tooth comb, and you begin combing in small sections, starting at the very bottom ends of the hair, slowly working your way up toward the scalp.
If you start at the scalp and try to rip the comb downward through the tangle, you're just compressing the knot and ripping the hair follicles right out of the resident's head.
Exactly. It's incredibly painful and damaging. Bottom to top, ends to root.
Okay, so we've covered the exterior grooming, the skin, the limbs, the nails, the hair. Now I want to pivot. Let's talk about an area of hygiene that technically happens inside the body, but has immediate, profound consequences for the respiratory system. Let's talk about oral care.
Oral hygiene is often treated as an afterthought by tired staff, but clinically it is paramount. The bacteria that build up in dental plaque are directly linked to cardiovascular disease and, most dangerously for the elderly, severe respiratory infections.
Let's start with a resident who uses dentures. Dentures are custom-fitted, highly fragile, and incredibly expensive. When a CNA takes them out to brush them, the exam wants to know the exact physical setup of the sink.
Before you even pick up the denture brush, you must line the basin of the sink with a clean towel, or you plug the drain and fill the sink with a few inches of water.
I used to think this was just to keep the sink clean, but it's actually about physics, isn't it?
It is entirely about physics and impact. Dentures are made of hard acrylic resin. When you cover them in saliva, water, and toothpaste, they become slicker than ice. It is very common for them to slip out of a CNA's gloved hand. If you drop a hard acrylic denture into a dry, empty porcelain sink, it will shatter into pieces. By placing a towel down or having a layer of water, you create a shock absorber. If they drop, they bounce safely.
That's a great practical safeguard. Now, what about the water temperature we use to wash them? We hammered home that bathing water should be warm. Does that apply to dentures?
Absolutely not, and this is a massive trap on the exam. You must clean dentures using cool or lukewarm water only, never hot water.
Why? I feel like hot water would be better at dissolving the adhesive paste.
Hot water will soften and warp the acrylic plastic. If the denture warps even a fraction of a millimeter, it will no longer conform to the resident's gums.
Oh, that makes sense.
Yeah, it will cause agonizing blisters in their mouth, and they will be unable to eat. You've just destroyed thousands of dollars of medical equipment and compromised their nutrition. Cool water only. And when they are out of the mouth overnight, they must be stored in a denture cup filled with water or cleaning solution so the plastic doesn't dry out and crack.
Okay, let's look at residents who still have their natural teeth, but they have suffered a massive stroke or are comatose. How do you safely brush the teeth of a resident who is completely unconscious?
This procedure carries one of the highest mortality risks of any hygiene task a CNA performs.
I noticed this is actually one of those questions straight from Cert Prep Academy that tricks a lot of students. Because our natural instinct, based on going to the dentist ourselves, is to lay the resident flat on their back and open their mouth.
If you lay an unconscious resident supine, so flat on their back, and introduce any fluid into their mouth, you are almost guaranteeing aspiration.
Let's define aspiration clearly, because that word is plastered all over the NNAAP exam.
Aspiration occurs when food, liquid, saliva, or vomit is inhaled down the trachea, the windpipe, and into the lungs, instead of traveling safely down the esophagus into the stomach.
Because they can't swallow it.
Right. An unconscious resident has zero gag reflex and zero swallow reflex. If you put water in their mouth while they are on their back, gravity pulls it straight to the back of their throat and it floods directly into their lungs.
And when bacteria-laden mouth fluid enters the lungs, you get aspiration pneumonia, which is incredibly difficult to treat and often fatal in geriatric patients. So how do we clean their mouth without drowning them?
Positioning is your only defense. You must turn the unconscious resident completely onto their side, the lateral position. You turn their head so it is facing the side.
So now gravity is working for us, not against us.
Exactly. In the lateral position, any excess fluid in the mouth will naturally pool in the cheek and dribble out of the corner of the mouth onto an emesis basin or a towel, rather than draining down the back of the throat.
And what tool are we using? Are we using a standard bristle toothbrush with a cup of water to rinse?
No, standard toothbrushes are too abrasive for a dry, unconscious mouth, and pouring water to rinse is strictly forbidden. You use a specialized tool called a toothette, a small sponge on a stick. You dip the sponge in a tiny bit of water or mouthwash, and you squeeze out all the excess liquid before it ever enters their mouth. The sponge should be barely damp. You gently swab the teeth, the gums, the tongue, and the roof of the mouth. And you should always have a mechanical suction device turned on and ready to immediately clear any pooling saliva.
Side-lying position, minimal moisture, sponge swab, never force a rinse. That makes total physiological sense.
It's all about mitigating the risk to the airway.
Okay, so we've thoroughly explored the entrance to the digestive tract. Now we have to look at the exit. Let's talk about elimination, perineal care, and incontinence. It's not glamorous, but it is deeply vital.
Pericare is the bread and butter of the nursing assistant role. And there is one non-negotiable rule that dictates how you perform this, specifically for female residents.
Always wipe from front to back.
Yes. From the urethra backward toward the anus. Never, ever the other way around.
I hear that rule constantly, but play devil's advocate for me here. If I'm using a washcloth loaded with soap and the whole area is going to be cleaned anyway, why does the direction of the stroke matter so drastically?
It matters because of the specific anatomy of the female urinary tract and the specific bacteria involved. The gastrointestinal tract is full of Escherichia coli E. coli. In the colon, E. coli is normal and harmless.
Right.
But the female urethra, the tube that leads to the bladder, is extremely short, usually only about 1.5 inches long, and the opening is physically very close to the anus.
So if you wipe from back to front,
If you wipe from back to front, you are physically bulldozing a colony of intestinal E. coli directly over the vaginal opening and pushing it straight into the urethra. Because the urethra is so short, those bacteria swim right up into the bladder.
and the bladder is supposed to be sterile.
Yes, the bladder is a sterile environment. The bacteria multiply explosively, causing a severe urinary tract infection or UTI.
And a UTI in an 85-year-old resident is a completely different beast than a UTI in a 25-year-old, right? Yeah.
It is night and day. Younger people experience localized symptoms burning during urination, pelvic pain, but in the elderly, their immune response is altered. The infection often bypasses localized pain and crosses the blood-brain barrier, causing profound neurological symptoms.
Wait, like what?
The resident will suddenly exhibit severe confusion, hallucinations, delirium, and aggressive behavior.
It literally mimics a sudden onset of dementia.
Exactly. And if it isn't caught immediately, the bladder infection ascends into the kidneys and from the kidneys into the bloodstream, causing urosepsis, a massive systemic life-threatening inflammatory response.
That's terrifying.
I've seen countless elderly residents end up in the ICU on IV antibiotics, hovering near death, entirely because of improper wiping technique. Front to back is a literal lifesaver, and you must use a different section of the washcloth for every single downward stroke so you don't smear bacteria back onto the skin.
Okay, front to back for females. What about male residents, particularly a male resident who has an indwelling urinary catheter, like Foley catheter?
The underlying principle of keeping bacteria away from the bladder remains the same. The catheter tube enters the urethra at the meatus. You must clean away from that sterile entry point.
Okay.
You hold the catheter tubing gently near the tip of the penis to prevent tugging on the internal balloon, and you wipe down the tubing away from the body for about 3 to 4 inches.
So wiping outward, away from the resident. If you wiped up the tube toward the body, you'd just be pushing microscopic debris right into the urethra.
Precisely.
Let's talk about the reality of incontinence. A resident loses control of their bladder or bowels in bed. The standard procedure is prompt removal of wet clothing, thorough cleaning, drying, and applying a moisture barrier cream. But let me push back here, taking the perspective of an incredibly stressed, understaffed CNA who has 10 other call lights blinking.
I've been there.
If I have a resident who is totally immobile and I know they're incontinent of urine every hour, why shouldn't I just put them in a heavy-duty adult brief, wrap the area securely, and just check them at the end of the shift? Wouldn't that save time and keep the bed dry?
That mindset is exactly what the state examiners are trying to identify and weed out. Putting aside the profound loss of human dignity, I mean, forcing a human being to sit in their own waste for 8 hours, the clinical consequences are catastrophic.
What happens to the skin under those conditions?
Urine is highly acidic and contains concentrated urea, which breaks down into ammonia. If urine is trapped against fragile elderly skin for hours, the ammonia destroys the skin's natural acid mantle, causing painful chemical burns.
It's essentially bleaching the skin.
Yes. Furthermore, wrapping the area tightly in a plastic-backed brief creates a localized greenhouse effect. It traps body heat and liquid. The epidermis absorbs all that moisture and becomes completely waterlogged. We call this maceration.
Like when you stay in the tub too long?
Think about how your fingers look after you've been in a swimming pool for 2 hours, white, wrinkly, and soft.
Yeah, the skin feels like it could easily scrape off.
Now imagine that macerated, chemically burned skin being pressed against a mattress with the weight of the resident's pelvis. The slightest bit of friction will tear that weakened skin wide open. Now you have an open wound soaking in a mixture of urine and feces.
Oh my gosh.
That is how massive infected pressure ulcers form in a matter of hours.
So the exam trap answers that suggest wrap tightly in plastic to contain leaks are absolutely lethal. What about using baby powder? People use talcum powder on babies all the time to keep them dry.
In a clinical geriatric setting, powder is a hazard. When powder mixes with urine or sweat, it doesn't stay soft. It clumps together into hard, abrasive little pellets.
Oh, I hadn't thought of that.
These pellets get trapped in the skin folds and act like sandpaper rubbing against the epidermis, causing severe friction damage. Not to mention, shaking powder creates an airborne particulate cloud that frail residents can inhale, irritating their lungs. Gentle cleansing, patting dry, and applying a zinc oxide barrier cream is the only correct path.
Okay, for residents on bed rest who are continent but cannot walk to the bathroom, we use a bedpan. But you can't just slide a piece of plastic under someone and walk away. How does the exam want us to position them?
Positioning is everything for elimination. The correct answer for a bedpan is placing the resident in a semi-Fowler's position. This means the head of their bed is elevated somewhere between 45 and 90 degrees, sitting them upright.
Why can't they just use it lying flat on their back?
Human anatomy. Try swallowing a piece of food while lying perfectly flat. It's incredibly difficult because you are fighting gravity. The digestive and elimination tracts rely on gravity. If a resident is lying flat, they have to strain their abdominal muscles immensely to defecate.
Which is hard for a frail person.
Exactly. For a frail resident or someone with a heart condition, that Valsalva maneuver, that intense straining, can actually trigger a cardiac event. By sitting them upright in semi-Fowlers, gravity does the work. Also, if they're flat, urine will just follow gravity backward, up their spine, and spill all over the bed.
Gravity always wins. And is there a time limit for how long they can sit on it?
10 to 15 minutes is the absolute maximum. A bedpan is constructed of hard, unyielding plastic. If you leave a resident sitting on that narrow plastic rim for 45 minutes, the concentrated pressure will cut off circulation and cause a pressure ulcer on their coccyx.
So what if they haven't gone yet?
If they haven't produced anything in 15 minutes, you remove it, reposition them, and try again later. And remember, always promote their independence. If they have the dexterity, you hand them the toilet tissue and let them clean themselves first.
Because maintaining independence is how we maintain dignity. Okay, we've covered the bedbound hygiene, but eventually we need to get these residents up. They need to get to a chair. They need to go to the dining room to eat. This brings us to the mechanics of movement and fueling the body. Transfers and feeding. Let's start with feeding. The resident is out of bed. It's lunchtime. What does the exam prioritize when we are assisting with a meal?
Posture and positioning, again, are paramount. The resident must be sitting upright, at least 45 degrees, but ideally at a 75 to 90 degree angle in a chair.
Because if they are slouched down, we run right back into our old friend, aspiration risk.
Exactly. A slouched posture misaligns the esophagus and the trachea, making it dangerously easy for food to sleep into the airway. Now, where should you, the CNA, be positioned while you are feeding them?
My instinct, if I'm busy, is to just stand next to their chair and spoon the food in quickly.
And the exam will offer that as an option, but it is entirely incorrect. The rule is that the CNA must sit down in a chair directly facing the resident at eye level
Why is sitting so strictly enforced?
for two reasons,
Mm.
psychological and clinical. Psychologically, if you are standing over someone, looming over them, it subconsciously pressures them to hurry up and eat faster, which leads to choking. Sitting down communicates, I have time for you, you can relax.
That's a great point. And clinically,
Clinically, sitting face-to-face at eye level allows you to intimately monitor their oral phase of swallowing. You need to be able to see if they are pocketing food in their cheeks like a chipmunk, and you need to watch the rise and fall of their larynx to ensure the food is actually going down.
because if it isn't going down properly, we're dealing with dysphagia difficulty swallowing.
Yeah.
What happens if I'm feeding a resident, they take a bite of chicken, and suddenly they start coughing violently?
The absolute first thing you do is stop feeding them. You pull the spoon away and you notify the nurse immediately. Coughing is the body's emergency alarm system. It means material is actively touching the vocal cords and threatening the airway.
But wait, if I'm at a restaurant and I choke on a dry piece of bread, my immediate reflex is to grab my glass of water and chug it to flush the bread down. Why can't I just offer the coughing resident a sip of juice?
Because that is how you turn a minor coughing fit into a fatal aspiration event. Think about the physics of liquids versus solids. A solid piece of food moves relatively slowly. If their throat muscles are already uncoordinated and struggling to manage a slow-moving solid, introducing a fast-moving thin liquid is disastrous.
Oh, I see.
The liquid will rush past the solid food and pour directly into their open airway. Never attempt to flush down food. You stop, you encourage them to cough it up on their own, and you get medical intervention.
And what if the resident has unilateral weakness, like from the stroke we talked about earlier? One side of their face is drooping.
You must place the food onto the stronger, unaffected side of their mouth. The strong side retains the muscle tone necessary to manipulate the food bolus and initiate a safe swallow. If you put food into the paralyzed side, they can't feel it, they can't chew it, and it will just pool there until it eventually slides down into their airway.
The exam also touches heavily on altered diets. Can we briefly clarify the difference between a clear liquid diet and a mechanically soft diet?
Sure. A clear liquid diet is prescribed for residents recovering from gastrointestinal illness or surgery. The rule of thumb is, if you can hold it up to the light and see through it, it's allowed. Water, apple juice, plain gelatin, clear beef broth.
So orange juice is out.
Orange juice is out because it contains opaque pulp. Milk is out. A mechanically soft diet, however, is very different. This is for residents who have their normal digestive function, but they lack the physical ability to chew. Maybe they have severe dental pain or no dentures.
Okay, so what can they eat?
The food is normal, but the physical texture is mechanically altered. The meat is minced or ground up. The vegetables are cooked until mushy. It requires minimal jaw strength to process.
Okay, the last major mechanical concept we need to unpack is transfers and ambulation. Moving the resident safely. Let's talk about the gait belt or transfer belt. This is the heavy canvas belt with the metal buckle that the CNA uses to stabilize the resident. When exactly does it go on?
The gait belt must be applied securely around the resident's waist, over their clothing, before they ever attempt to stand up from the bed or chair.
We actually pulled the specific gait belt question from the Cert Prep Academy question bank because it is notoriously tricky. A lot of students choose the answer that says, apply the belt after the resident has stood up so you can adjust it for a tighter fit.
Which completely defeats the entire purpose of the device. Think about the biomechanics of a transfer. The absolute most dangerous fraction of a second, the moment the resident's center of gravity is completely unstable and their knees are most likely to buckle, is the exact moment they transition from sitting to standing.
Right.
If the belt is sitting on the bed next to them during that upward lift and they start to fall, you have absolutely nothing to grab onto except their fragile arms, which you will likely dislocate. The belt must be secured while they are safely seated.
Okay, the belt is on. They're standing up. They have their walker. We're going to ambulate down the hallway. Where does the CNA physically position themselves?
You stand slightly behind the resident and slightly to one side. Specifically, you must stand on their weaker side.
I always have to think through the physics of this. Why not stand on the strong side to help support their good leg and pull them along?
Because your job isn't to pull them, your job is to catch them. You stand on the weak side because that is the side that is going to collapse.
Oh, that makes sense.
If a resident has a weak left leg from a stroke and that knee gives out, Their body weight is immediately going to pull them down and to the left. If you are standing over on their right side, you are totally out of position. You are on the wrong side of their falling center of
You
gravity.
never catch them in time.
Exactly. But if you are already standing on their left side, with your hand firmly under the gait belt at the small of their back, your body acts as a physical brace. When they buckle to the left, they buckle right into you, and you can either stabilize them or safely, slowly guide them down your own leg to the floor.
It really all comes down to physics, anatomy, and anticipating the failure points. Looking back over everything we've discussed today, from the exact temperature of bath water, to the shearing forces of a bedsheet, to the trajectory of E. coli, to the physics of a gait belt, it becomes so clear that none of this is just arbitrary busy work. This is the absolute core of compassionate scientific care.
It truly is. When you are taking the NNAAP exam and you feel frustrated by a hyper-specific question, remind yourself the exam isn't trying to trick you just to be mean. It is testing your critical thinking to ensure you can protect the most vulnerable people in our healthcare system. Every single rule, every protocol exists because someone, somewhere in the past, suffered harm when that protocol wasn't in place. You are learning the science of keeping people safe.
That is an incredibly profound framework to use while studying. These rules are the safety net. Okay, my friend, we have covered an immense amount of clinical ground today. Let's do a rapid-fire 1-minute recap of the absolute must-know, non-negotiable concepts from this deep dive.
Let's lock it in.
Number 1, bathing water temperature.
105 to 110 degrees Fahrenheit, and you always test it on your own inner wrist first.
Number 2, dressing a resident with unilateral weakness.
DAF, dress affected first, on with the weak, off with the strong.
Number 3, perineal care for female residents.
Wipe from front to back, from the urethra toward the anus, to prevent devastating E. coli UTIs.
Number 4, oral care for an unconscious resident.
Turn them into the lateral side-lying position to prevent aspiration pneumonia, and use a barely damp sponge swab, never a toothbrush or a cup of water.
Number 5, nail care.
Cut straight across, but if the resident has a diagnosis of diabetes, you do not touch those clippers. Hard stop.
Perfect. That is the foundational gold right there. Now, as promised, I want to make sure you have every single tool you need to crush this exam. We've referenced several specific physiological scenarios and test questions today, and if you want to test your own recall on them, you need to head over to certprepacademy.com.
It's simply an incredible resource because it removes all the guesswork from your study routine. You get to interact with the material exactly how you'll see it on test day.
Exactly, and the absolute best part, it is completely free. There is no paywall, no credit card required, no sign-up necessary to get started. They have a 70-question practice test that perfectly mirrors the real NNAAP exam, giving you the exact feel and pacing of the actual test.
That pacing is so important to practice.
It really is. They also provide comprehensive free study guides that cover every single topic on the exam, breaking down the underlying physiology just like we did today. And they have flashcards to help you lock in all those tricky clinical terms like maceration, shearing, and aspiration. Everything you need to pass this exam is sitting in one place and costs you nothing. So do your future self a massive favor. Go to certprepacademy.com right now. The link is right there in the show description.
Transitioning from passively listening to a discussion to actively testing your recall with those questions is how you guarantee a passing score.
Well, study partners, we did it. That is episode 1, officially in the books. I am so incredibly proud of you for showing up today and putting in this intensive mental work. Sitting down to study complex physiology isn't always glamorous, but it is the literal bridge between where you're standing right now and holding that CNA certification in your hand.
Keep this momentum going. Take a break, drink some water, review your notes, and when you are feeling refreshed and ready, we will be right here waiting for you in episode 2.
But before you click away, I want to leave you with one final thought to mull over as you go about your day. We spent an hour today talking intensely about physical safety, about testing water temperatures, preventing friction tears, guarding the airway, holding the gait belt tight. We are trained to guard against physical harm. But I want you to ask yourself, when you are providing the most intimate physical care a human being can receive, when you are bathing someone or cleaning them after they have lost control of their bowels, how do your words, your facial expressions, and your silent body language protect their emotional safety? Because true care, the kind of care that elevates a good CNA into a great one, protects the dignity of the person inside the body just as fiercely as it protects the skin on the outside. We'll see you episode 2.